Welcome to CQC Connect. My name's Ted Baker. I'm Chief Inspector of Hospitals at the Care Quality Commission. Here at the CQC, we've been engaging regularly with a group of senior clinical emergency department staff from hospitals across the country to understand the pressures that they've faced over the COVID pandemic. The group has shared the steps they've been taking to manage the infection risk, to adapt to the social distancing rules, and to ensure that the best possible care is provided to patients under these difficult circumstances. As well as speaking to some of the group as part of this podcast, we've also been working with them to help develop an online resource called Patient First. The resource aims to help emergency department staff, hospital trusts, and local systems to build on the positive changes brought on during the peak of the pandemic. I'd encourage you to take a look at it. It's available on our website, and the link is in the episode's notes for this podcast. This is important guidance, and I'm really very grateful to the clinical experts who've given us help and support in bringing it, and we hope you'll find it useful. This episode is part of a mini-series looking at emergency care through the lens of the coronavirus. We'll be talking about what challenges there have been, sharing learning and innovation, and hearing from clinicians who are working on the front line about how they are tackling the issues. Today, we're focusing particularly on infection prevention and control, and I'm joined by two members of our National Emergency Special Advisors Forum. Can I ask you to introduce yourselves? James, do you want to start?
I'm James Hill. I'm Head of Nursing for A&E and Acute Medicine at Guy's and St Thomas's.
Okay, thank you, James. Welcome. And Sally, would you like to go next?
Thanks, Ted. Hello, my name's Sally Young and I'm the Quality Assurance Matron at Morecambe Bay Hospitals. I've got quite a diverse role and my background is A&E and emergency planning and do my clinical work as a nurse practitioner and a non-medical prescriber around A&E.
Okay, Sally, James, thank you very much for joining us today, and I look forward to a stimulating discussion. Could I start by asking you to tell us briefly about the impact of coronavirus in your area of work, and what have been your biggest challenges or concerns, particularly as we head into winter? James, do you want to lead off on this?
Yes, sure, thank you. I think in order to answer that question, you have to look at the beginning of the coronavirus when we thought it was coming or knew it was coming. And I think part of the issue we had was the unknown. Also, the anxiety and fear of not knowing what was coming our way, and certainly the experience of China and Italy, and managing staff expectations, organisational expectations, and certainly the country's expectations of how this was going to impact. I think there was a lot of fear and anxiety that was brought from the media, the public, as well as professional anxiety when we saw the health systems not coping in other countries. Part of that then actually led to a huge planning mechanism, I suppose, in the organisation, where we were trying to plan for the unknown in this tsunami that was about to hit us. There was the sense of, would we have enough PPE? Would we be able to maintain safe practices? Would we have enough capacity? Also around actually people knowing that they may well catch it themselves, and the fear of what it would do to them, and possibly decimating the workforce. Fortunately, we've come through the first wave, and some of those anxieties were alleviated in terms of once we got into the rhythm of COVID, and we put infection control measures in place and certainly systems in place to move patients through the department and move people into the main hospital. We got into what we call a battle rhythm of how we make sure people are cared for in a safe way, but also in a professional and caring way, notwithstanding the fact that people weren't able to have their loved ones with them during that care. So I think that added another burden that's still living with us somewhat. In terms of where we find ourselves now, we are seeing patients returning back to the department in terms of the majors side of things. So we're absolutely seeing our patients back to normal numbers from that perspective. The urgent care side of things is on the up, but it is not a particular challenge for us. So what we're finding ourselves at the moment is, how do we manage the majors type patients, and how do we manage what people know as green, amber, red pathways, or COVID, non-COVID pathways. And we've actually increased our footprint of the department. So we've created extra major space and moved some of our urgent care out of the department, but on the same floor. So we've managed it from that perspective. In terms of the challenges going forward now, crowding is still an issue, and certain peaks during the day. Being in a London central teaching hospital, we do see peaks as we did pre-COVID. So around lunchtime, we're seeing them in the afternoon and into the evening. So we are looking at ways of managing our flow. We've created different pathways in order to manage that flow so that we can decompress the department. But we are still challenged when we do see surge of patients arriving at the front door. I think the thing that's living with us now is the anxiety of the second wave and what the impact of the second wave will be. Certainly London was the epicentre of the first wave, and now northern regions seem to be the epicentre of the second wave. It hasn't quite got down to certainly our organisation at the moment. So we are really starting to see the heat be turned up, should we say, and we are managing to keep on top of that, but it's a real challenge in terms of keeping our capacity free to move people through and not have people crowding in ED. We are still managing to be fairly successful around that. The main challenges then now is around the workforce and PPE. So PPE, we do have enough PPE, and we are keeping on top of the PPE requirements, but certainly it's around getting fit testing as we are now going to reusable masks, especially for the emergency floor and people that will need them regularly. So it's around the fit testing. It's also around people's resilience. People haven't had holidays that they're traditionally used to, so therefore they haven't had the downtime. And there's the resilience of going forward for winter and the anxiety of not knowing whether flu is going to be a problem and where we find ourselves, and certainly the anxiety of whether or not we'll end up with crowded departments again that we're not going to be able to manage. And I think the other part is around people have not seen their families. So lots of people are suffering from not having their family units around them. Certainly we've got a lot of overseas nurses that have managed to get home and have to quarantine. There are actually quite a few people around that. There's also a fair amount of staff that are of a certain age where family members are old and vulnerable. And so there's an anxiety that people are not seeing their loved ones and may not see their loved ones should anything happen to them, that actually, they die and things. And there's the element of what's termed psychological injury from the first wave, things that people didn't see, especially younger staff who newly qualified, people who are not used to major incidents, are not used to seeing such a burden put on them on a daily basis. And I think that's been the sort of real challenge from my experience.
Sally, a similar experience about the challenges that you think are coming up in the winter of COVID?
Yes, thanks, Ted and James. Yeah, I think you've covered a lot of the things which is very similar to our organisation. We are a 5-site hospital trust with 2 A&Es around sort of a 50-mile radius, and the challenges that we found was actually the departments were really difficult to actually turn into COVID secure isolation areas, particularly the hospital round at Barrow. So what it's meant for us moving forward is that we've looked at our real estate and we're actually doing some work to improve the actual physical layout of the department. So that was a challenge for us. I think moving forward, I would totally agree with what James has said, but moving forward for us at the moment, the challenge that we've got is around balancing the elective work that we've started to do and actually need to do, because we've been seeing some quite poorly patients come through the door that have maybe had treatment delayed for various reasons. And that's balancing having the need to actually look and review our surge plans, which we are doing now. But when do we actually push that button to open those wards back to COVID secure areas and separate areas and not use our side rooms, which all has an impact, obviously, on the flow through the department in A&E. I think the challenge for us moving forward is that the redeployed staff that we had in the first wave are not there now, or not there or as readily available as they were. And we relied a lot on those individuals coming forward and supporting the department and indeed all the areas. So it's about balancing who you've got and the skills that they've got and the activity. And I think for us at the minute, that's where the apprehension lies.
Okay, thanks, James. Sally. There are a lot of challenges there that all units across the country will be facing. Some will be relatively localized to their unit, but a lot of them are general. And I think the importance of the patient first document is it has guidance on many of those challenges brought together from across the country. So again, I'd say to our listeners, do have a look at that, because many of those challenges will be addressed in there. Not that there are simple solutions, but at least you'll know that you're sharing the best solutions that our clinical experts can provide. We're focusing today on infection control, though. That's the purpose of this podcast. So can I come back to you, Sally, and ask, what do you think a trust needs to do to ensure effective infection control in the emergency department this winter during the COVID pandemic? Sally.
Thank you. I think the most important thing is to absolutely maintain that close working relationship with the infection prevention teams and the staff that have got that specialist knowledge advice, and actually listening to them, and then using our emergency department skills and knowledge, how the department works, the flow, etc., and actually turning them into reality. I think it's about empowering the staff to be able to challenge people when they come into the department, and actually control the entry into the department helps reduce the risk. I think it's really important that we have risk assessments, and the risk assessments, it's not just job done if the box is ticked. It's actually people understand what the risk assessment means to them, their team members, and actually the patients they're looking after. And also that multidisciplinary aspect of it, that the ambulance service, the radiology teams that may come into A&E actually understand what they need to do to keep themselves and all of us safe. Signage, I think, is absolutely vital. We talk about signages on the door, on the floor and in the sky. They need to be clear, they need to be corporate, and you don't need too many of them. That's a really important thing. I think as well, that information when we're taking patients to the ward about that person's infection status, whether they're positive or whether they have any other infection issues, is really important, and we communicate that properly and move those patients around the hospital safely. So that's why we need to make sure that we know that our porters and our teams know exactly what they're doing and why. And I think that really, for me and for us, is the most important part of keeping the department and each other safe.
Yeah, I'd echo a lot of what Sally said. I think in addition to that, I think there's a couple of things in terms of, from my experience, is plan, talk, I would say. So actually get your assessments done, get your planning done, talk to staff, operationalise it, plan again to see that you're still going in the right direction, and talk again. I think key relationships, you've got to have your key relationships with medical wards. I'm fortunate that I'm head of nursing for medicine as well, so I'm able to influence that. But I think for areas where A&E is just siloed within A&E as a specialism on its own, you've got to have the networks in order to be able to move people on in a timely way and understand what's going on. I think the other thing, just picking up on one of the things Sally said, around general infections, I know we're concentrating on COVID at the moment, but for example, if you end up with a norovirus outbreak or an outbreak of something that actually is equally as catastrophic to flow and catastrophic to the operational efficiency, you've lost it completely in terms of trying to deal with COVID and then flu and then something like norovirus as well. And certainly in winter, we all know that, you get the flus, you get the noroviruses. So I think people have got to be vigilant around other infections as well. It's not just around COVID, because we've got too many other balls in the air at the moment, so we don't tip over health systems. And I think also it's talking to your commissioners and understanding through your commissioners understand what pressures you're under and vice versa, so that they can help put mechanisms in place to help support things, especially what we want to avoid during this time, especially from the infection point of view, is having to go on diverts because a department has been overwhelmed from an infection.
I mean, one of the things that is going to be really challenging is social distancing in crowded waiting rooms. How are you managing that?
For us, it is a challenge because our waiting rooms is relatively small, because our departments are quite small because of the geography where we live. What we're trying to do is encourage that if anybody comes in, that if somebody brings them in, then they would wait in the car if safe to do so, not actually enter the department and only have the patient. But obviously we wouldn't not let anybody come in with them if they needed to, but not a whole family trooping in, because they're putting themselves and each other at risk as well. So I think that's really important. And also, if possible, to try and have an area as an overflow area. And like James says, think ahead, that area won't necessarily be used all the time, but it's in the bag there ready to use should you need to. And I think that's where A&E are very good at being flexible. And because every day, like you say, it's not just COVID, is it? We get challenged by lots of different things. And I think one thing we are good at as clinicians is actually being flexible.
Thanks. So, James, can I come back to you? What do you think the barriers are about addressing these infection control issues? What's going to get in the way, and how can other people help the ED manage these barriers effectively?
I think we're at risk of becoming our own enemies and thinking we know what we're doing, and therefore we think we've got a solution before problems happen. And I can't emphasize enough, it's about being open-minded and about thinking outside the box and planning ahead for those scenarios. I think the other thing is staff, in terms of staff fatigue and staff's resilience being lower, resistance to change and resistance to being able to manage that change or manage changing horses midstream, so to speak, in terms of getting that done. I think also some of the other barriers is if you haven't got effective infection control links, or you haven't got effective relationships with the rest of the organisation, or the organisation itself don't own the front door issues, then that is certainly where the barriers will be. Certainly departments, in my experience, that end up with corridor waits and waits of ambulances outside struggle with getting buy-in from the rest of the organisation or the rest of the healthcare system. That is one of the key things, even pre-COVID, potentially was an issue, and may well be an issue going forward. And then I think that there's something around, we're all trying to keep the elective work going and the elective pathways going, because we are seeing people becoming more dependent when they come in because of not being able to access care during the first wave of COVID. I think part of the problem there is organisations will need to take a view about what activity can continue to safely go and what activity you will have to stop if we get to that stage. I think the first time round, there's very much a national drive to just cut everything else, so we didn't have the experience of Italy and other healthcare systems, whereas this time around we're a bit more sophisticated in knowing what we've got. But I think the risk is actually, as I say, tying that up with the rest of the infection control agenda and making sure your estate is fit for purpose. So certainly the Guy's site that I manage is a minor injuries unit, and as well as having GPs there. And we are looking at how that operationalises during the peak of COVID, because predominantly the patients going to Guy's are shielded patients, or what we know as shielded patients, so oncology, renal, those sorts of patients. So we are looking at two very different models on our different sites. Same as Sally is doing across the sites that she manages. And ultimately, I think there's something around working as a health system, as I alluded to, people not going on to diverts in a sort of flippant manner because they're struggling. We've got to work together as a health system and a health economy in order to maintain that, and including the GPs and ambulance service with that. We're working with 111 to get people in a 111 first sort of setting. And we've got to make sure that works, and we can't allow our own sort of prejudices and feelings around that to scupper that, because I think we've got to keep open-minded, no matter how tired and how many times we go around the loop of trying to sort some of these issues out. We've got to be open-minded to keep that going.
Yeah, it's interesting point you make there about the relationship between the emergency department and the rest of the system within the hospital and outside it, and how important that is. So many things. I think you said there, James, it was important anyway, but of course infection control makes it even more important. And that really, and if people look at our patient first document, they will see that it's aimed not just at emergency departments, but in the system that supports emergency departments. And it's important there's some common ownership for the problems emergency departments are facing going into winter. Sally, anything you want to add on barriers?
I think for us, obviously, the picture around COVID or any infection moves very quickly. and the guidance that you may be giving out and asking people to abide to could change on a daily basis, which, you know, in the beginning it actually did. And that, I think, is a risk, and a risk that, you know, is potentially there for us again. I think the only way to try and mitigate that risk is to try and involve those people to make sure that they comply, because the people on the floor are the people that are doing that every day. And while we may have the documents and the guidance that comes in from all our different organisations which are there to help us, it's about us supporting those hands-on operational staff to actually apply that guidance to keep themselves safe. And I think the appetite is there, but I think, like James rightly says, and you've alluded to, Ted, as well, is everybody's really tired. And, you know, you're going in asking them to do something again, and you can tell that they're just like, they're here again. But I think it's about empowering those people and actually involving them to be able to have the ownership of being able to apply that guidance, because they know it's right. But it's a challenge, and that for me is the biggest barrier about infection prevention in any part of the service at the minute.
Yeah, I mean, one of the things we emphasise in Patient First is the importance of leadership and culture and building that right culture, because people are facing difficult challenges and complex problems, and they need that confidence and support. James, you want to come back in?
Yeah, just one thing I think really is an important barrier, especially with people being tired and omissions or lapses in care, is around guidance coming out and changes of guidance that Sally just brought up. I think what we experienced the first time, and certainly the schools have said that they're experiencing now and getting people back to school, is the guidance comes out thick, fast and furious with more we know, and it's about the timeliness of implementing that guidance. So what we really avoid doing here at Guidance and Thomas is guidance coming out at 5 o'clock on a Friday, trying to implement that over the weekend. It's having timely, sensible implementation of guidance, because again, what we don't want is omissions in care or lapses in care that ends up causing, you know, transmission in hospital because we've made mistakes. And certainly, as we get busy, we will see that if we're not careful.
Yeah, I think as well, I think we have to think about the messages that we share. If for whatever reasons there are lapses in care, is that we actually make sure that people learn, not just for those people that have been involved in that care, but actually for us as senior leaders, that we actually make sure that those lessons are shared right across the organisation. Because actually, if there are breaches to do with infection prevention, they may be happening in other areas of the hospital as well. And I think it's about learning from each other and making sure that, you know, the staff are aware of what they need to do, but in a really positive manner, because that will help us to then make sure that staff comply.
Yeah, one of the really good things I've seen coming out of COVID in some services is they've developed a really strong learning culture around the bedside. So when things go wrong, as they do in any busy service under pressure, then there's immediate learning about how to prevent those problems occurring. And of course, that would apply in a busy emergency department under pressure and would apply to infection control. So I think that kind of bedside learning culture is absolutely vital to doing this well. Sally, is there any other innovative practice that you want to cite in terms of really good practice around infection control?
Yeah, I mean, there's some in the document, isn't there, Ted? But I think for us at Morecambe Bay, I think it's about thinking about a designated PPE or safety officer that's actually there to support the individuals at the donning and the doffing stations, to make sure that there's somebody there to make sure that before they go into those areas that are actually their PPE is on correctly and they are safe to go in. Because when you're taking it on and off, day in, day out, it becomes really tiresome. And I think that for us has been a really good role. And it can be anybody, you know, whoever is available, but actually designating somebody to take that gives that sense of ownership for both people and team spirit as well. For us, certainly some of the pathways that we have within the organisation are much more robust now and have continued to be so. We also had what we call the Red Hub with our GPs, which was where any suspected COVID patient that was well enough to go to there was set up separately, and that helped to keep the flow through the department. And then just little things like stickers on uniforms. We've got an iPad for patients to use if they want to communicate with their family, obviously cleaning it in between, etc. And most importantly, like we've both alluded to, is about learning lessons, not just from things that go wrong, but from good practice as well. And we really try to keep that positive slant on it, particularly when the times are really difficult early on.
There are lots of good ideas there. James, you got any you want to add in?
Yeah, so I think we some of the things we've done which are working really well. We've created a multi-specialty assessment unit. So actually we took the concept of ambulatory medicine and our CDU pathway, and we're fortunate that they were co-located next door to each other. And we've actually opened it up as a multi-specialty area. So what we do now is when patients are ready to be seen by a specialty, or we want the specialist's opinion, we move them through into that space. It's a sort of 30 spaced area. We've also created some waiting space in there with partitions, so people can actually sit sort of next to each other with partitions. So we've managed to maximise our waiting space. And if patients are bound or admissions, they go straight to the ward, so we're not delaying care there. Actually, it does decompress ED quite effectively. We've also split our say urgent care pathways, so we've now got GPs in one area of the hospital, and we've now got minor injuries in another. So it's sort of going back to the old days, but actually it's helping decompress things. And also we were able to manage flow better that way by giving appointments and talking it that way. We've also redesigned our front door assessment process. So we've actually now got when you walk into the department, we always had a nurse meeting at the front door to do a 1 minute assessment, but actually what we do now is we do proper per set of obs, work out how we are going to get the patient to a destination where they will be treated with a one-stop assessment at the front door. And we've got what we call a task team there that follow on those tasks and then get them to the area. And we're also about to implement Band 7 mental health nurses at the front door to do mental health assessments. So we've created assessment rooms at the front door. And we've got mental health nurses that will do that first look mental health assessment in order to speed up that process. And then we've built on our huddles, our 2 hourly huddles that we have in the department. Actually, we do a look forward around what can go to an SAU, what are the barriers for mental health, etc. And finally, the thing which I think has been the most successful bit is we've built on the relationships that we've had elsewhere in the organisation. So, for example, going back to the multi-specialty assessment unit, specialties are coming to me now asking me what else we can put through the multi-specialty area, because they're realising the benefits of getting the patients through and out quicker. So it's gaining legs, and actually people are wanting to engage in that.
That sounds really interesting. Sorry.
I was just agreeing with a lot of the things that James has said, and I think that those relationships moving forward are absolutely going to get us through winter and whatever the next few weeks and months will bring, be it COVID or any other infection. And certainly people that we knew by name, we now know by face, which I think is really nice. And again, people are continuing to think different ways of being able to improve the service.
And Ted, can I come back on one thing there? I suppose I'm painting a very rosy picture of how the relationships are all working together. I think the culture that you have to adopt, though, is also a culture where people can respectfully disagree with each other as well, and respectfully put forward a different view of how to do things. Going back to my earlier point about keeping an open mind, we have to be able to professionally challenge each other when we're not necessarily agreeing with the direction of travel. And I think that is a key to a really successful pathway organisation is people respectfully disagree and then respect each other's views around that. It's not all about being roses in the garden and one constituent of the patient pathway having dominance over another. It's got to be collegiate working.
Yes, Sally.
I think as well, we've got to acknowledge, like what James says, it's not just about the individual pathways. One area of the service or the hospital may be under more pressure than the other, and it's about supporting each other cross specialty as well. And like you say, there is a patient there that we're looking after, and while we respectfully will disagree and challenge each other, we've not got to lose focus of that, and I think that's really important. And sometimes we do, but we must stop and think, the impact that it's having on that individual, particularly at this really challenging time.
I think the other thing we've got to be mindful of as well as we go back into second wave, second surge, is that we also have to be the patient's advocates because their families are not there with them. It's really important, and I can't emphasise that enough. We've got to put ourselves in the patient's shoes and actually advocate for what the patients need. And that's whether you're working in ED, it's whether you're working in gynecology, it's whether you're working in mental health. We've got to make sure we are the patient's advocate here, especially as some of those patients will go on and become end of life, or will go on and become really debilitated by these people, by the situation they're going through. And actually, we've got to look ourselves in the mirror at the end of this and say we did right by the patient.
Absolutely. And I think the fact that the patients don't have someone with them, does change the dynamic quite significantly. And I think your insight into that really is important, James. So thanks. Can I just ask you for just one top tip about infection control? So if there's one thing you wanted to say to your colleagues around infection control, what would that be? Sally, do you want to lead off?
Yes, so the notes that I've made, obviously our document is called Patient First, but actually it's about involving the patient, and it's the patient that we're there to look after. It's about explaining to them why we're doing what we're doing, why we are dressed like we are, what they need to do to keep themselves safe, and then communicating that to each other within the department and across the organisation. And that for me, I think is the most important thing about that, because those patients are very scared. Seeing us all dressed up in all our gear is even more scary. Having to wear a mask, for longer than just doing the shopping is quite alien to a lot of people. So communication, as always, to me is most important, but it's involving those people and families in whatever way you can.
My top tip, as I've alluded to throughout the whole of this conversation, is plan, talk about things, and then plan again. Because your first plans won't work necessarily 100% the first time round, and actually keep an open mind. Plug the document in terms of read the document and then try and overlay that to your own department and current guidance around that, because not everything we say in the document one size doesn't fit all, or actually one size can be tailored to what you need to do. So, for example, the front door assessment process, I know a couple of other organisations that have taken the principles of what we've done and have implemented those, and they've been successful to manage their front door better than they have.
I've taken enough of your time. You've got busy jobs working on the front line, so thank you for your input. I can't bring your experience on working in EDs to produce a tip for our colleagues who are listening. But my tip would be read Patient First. Please do share it with people who you work with, both within your department, but also in the other parts of the system that provide support to you. It's not new guidance. It's not more guidance. It is a resource to help you, if you like, draw on the wisdom of some of your colleagues across the country about what works in emergency departments under pressure. So please do draw on it. Thank you, Sally. Thank you, James. It's been really interesting talking to you today. And thank you for everyone who's been listening.